Hazard of splinting. Splinting the
Sorry,
patient
so what exact situation would you use that?
on a femur fracture. So the top part of the leg, if
Mhm.
that's ever fractured, you would use a traction splint to what it does is that see, I hate not having visuals. So whenever you're you know which bone I'm talking about, the femur bone, right? The femur? You know
Yeah.
which one? Okay, cool. So whenever the femur breaks, when it breaks, it's going to overlap on itself, and the contraction causes the bones to kind of overlap and move on top of each other. So that's what causes the leg to shorten. So what the traction splint does is that it brings those bones apart and then slides them back into place. So during that sliding, when you're bringing those bones apart to bring them back into place, that's going to cause a lot of pain for your patient up until it's realigned. Okay, so it's for a femur fracture, and I just wanted to give you that visual. I just wanted to kind of give you the details to give you an idea of like what it's actually doing inside the body.
And will they feel relief right away, or?
Yes, just like you saw that patient, that one patient with the shoulder injury that was like almost crying, and then just went from like almost crying to like, oh my god, that feels great. Same, almost the same situation, but maybe just a lot more pain, to be honest with you. All right. So splinting the patient to death. Splinting before life-threatening conditions are addressed. Again, don't get caught up on some nasty-looking situations or nasty-looking breaks or flesh. Make sure your patient is alive and they're gonna stay alive before you treat that nasty-looking, non-life-threatening injury. All right, not insuring ABCs. So we talked about that. Too tight, so you can actually make the splint too tight to where you do not allow for circulation to continue. Too loose, which is you're pretty much doing nothing. If it's too loose, you might as well just do nothing. And splinting in deformed position. We always realign everything back in place except for the knee. Actually, just so there's two different kinds, and when we go in class, we'll go over both kinds. So amount of traction applied should be roughly 10% of patient's body fat. You wouldn't know that, so just go ahead and just pull until it's aligned back in place. There's a video here on splinting that I'm going to show you guys as well. So, new, share.
Signs and symptoms of a dislocated joint or fractured extremity include the following: exposed bone ends, joints locked in position, deformity, pain, paralysis, paresthesia, a prickly or tingly feeling that indicates a loss of sensation, or pallor, a pale skin color at the injury site. Splinting the extremity immobilizes the limb and prevents further damage to soft tissue, nerves, blood vessels, and the bones themselves. Effective splints always immobilize the adjacent joints and bone ends. Many types of commercial splinting devices exist that are usually categorized as rigid, such as a cardboard splint, formable, such as ladder or vacuum splints, and traction, such as hair or Sager splints. Traction splints are used specifically for femur fractures and will be addressed separately. Only stable patients with minor or isolated injuries should have individual extremities splinted on scene. Any unstable patient or a patient with life-threatening injuries should have his or her entire body immobilized on a long spine board and transported without delay. Take BSI precautions. Explain the splinting procedure to your patient, gaining his or her consent to perform the procedure. Any kind of manipulation of the extremity may be painful. Prepare your patient for the temporary discomfort, assuring him or her that immobilization will minimize pain thereafter, as well as prevent further injury. If possible, expose the area to be splinted. Utilize a second rescuer to hold manual stabilization of the bones above and below the injury site. Assess the patient's distal pulses, motor function, and sensation, or PMS, in the extremity prior to immobilization. A lack of distal circulation is an indication that you should attempt to realign the extremity. Realign the injury if deformed or if the distal extremity is cyanotic or pulseless. Continue until you achieve neutral alignment or the return of circulation. If you feel resistance, stop realignment and splint the deformed injury in place. Measure the splint to several inches beyond both joints, above and below the injury site. Measure the device on the opposite extremity if possible to avoid bumping and/or further injury to the extremity. With the second rescuer maintaining stabilization of the extremity, position the splint on or under the extremity. Pad the splint where necessary. Rigid splints need padding to avoid pressure points within the splint. Other splints may need padding in areas of void. Gauze, pads, towels, or other soft items can be used as padding. Secure the splint in place with cravats, cling, tape, or other fasteners. The device should be secure enough to prevent movement, but not constrict distal circulation. If using a vacuum or air splint, secure the splint, then adjust the air pressure. You may need to slightly adjust the straps once the pressure is adjusted. Recheck distal PMS now and periodically throughout the treatment and transport to ensure the splint was not applied too tightly or that swelling of the extremity is not creating a new situation where the splint is now too tight. If the splint is applied too tightly, loosen it immediately and reassess distal PMS.
So for pelvic injuries, see, pain in pelvis, hips, groin, and back. That's from pressure building up. That's from, at least in the back area, and nerve endings as well. See, pain when pressure applied to iliac crest, cannot lift legs. So all these are just indications that your patient may have a pelvic injury of some sort. Lateral rotation of the foot, that's a big indication because that means that your foot has gone upward, and that's an indication of a pelvic fracture. That's a serious indication. Unexplained pressure in bladder, bleeding from urethra, rectum, or vagina. So there are commercially available devices that you can use for the pelvis, but you can always improvise. And one really good tool to use for your patients with pelvic injuries that have a broken pelvis possibly is the KED. So the KED that you guys use to immobilize the spine for a patient that's sitting in a vehicle, if it's actually turned upside down and the fat end is put on the pelvis and the small end, which would go on the head, could be used to secure the feet in place or the legs together in place. And obviously, when we see each other, this is something else we're going to cover as well, because talking about it isn't going to be good enough. But this is one form. This is one commercial device you can use, and I actually have a YouTube video that talks about this one specifically, and I'll show it to you after this. If you don't have anything in place or any kind of device, a sheet like this right here, just fold it like this, works just fine for your patient. And then this just kind of goes through how to put it on the patient, how to strap it onto the patient, and it's real simple. So I'm gonna go ahead and show that right now then.